Welcome to Stablish, where EMS lives somewhere between stable and ish. I'm Josh Kingston, paramedic, educator, and your host. This podcast is for crews who work the chaos, manage the maybes, and make the call when protocol meets real life. The name Stablish comes from a familiar EMS dilemma: the patient who isn't crashing, but isn't stable either. They're not critical enough to demand aggressive intervention, but they're not the kind that you just walk away from. They're Stablish, this gray zone where decisions get nuanced, teamwork matters, and judgment meets protocol. Today, we are here with Ashley and Bill, and we're going to talk about LVADs. More specifically, what it's like for Bill to have an LVAD and to kind of live with an LVAD. And then Ashley's here as a coordinator with
the University of Kansas Health System.
And I'll let them kind of introduce themselves. So Ashley, if you want to go first.
Yeah, I'm Ashley. I'm one of the RN LVAD coordinators from KU. And yeah, I've been doing this about 8 years.
All right.
My name's Bill Cleek. I'm retired from electrical corporation, electrical utility provider. Spent 32 years with them, and I'm enjoying retirement really well. This has kind of been a little
other than having an LVAD.
Yeah.
Well, I just have to learn how to do things.
Yeah.
That's all.
Yeah. All right. Well, do you want to kind of tell me your story, your background, how you came to have an LVAD?
Well, I had my first heart attack 10 years ago. Yeah, just about 10 years ago, and it was a 100% blockage of the right coronary artery, and it hammered my heart pretty well. I didn't understand what he was talking about at the time, but he said it's either hibernating or it's dead. One of the two, that one part of my heart. Mine was more hibernating, and I got out of the hospital with a 39% lung function, which they consider congestive heart failure.
Yeah.
But through going to the gym and everything, I got it back up to 45. Well, how I did it, I don't know. I just did it.
Hard work.
And then fast forward here, I've been in the gym ever since. Eat right, don't miss a day hardly at the gym ever. And then all of a sudden I started getting short of breath, waking up in the middle of the night, just gasping for air. And it was September the 2nd. I woke up in the morning, and it wasn't severe, but there was something different about it. I couldn't get it to recover. I could always recover prior to this, but I couldn't use any of my little tricks to make it recover. So I called the EMS, and the next thing I know, I'm meeting these fine people in Kansas City. I went into ICU. To this day, I don't have any memories of that hardly at all. There was just I didn't understand why I was in ICU.
Yeah.
So my daughter explained it to me later, that it was really close and really serious. I didn't ever think about it that way. I just thought they're getting wires and cables and hoses all over me. I didn't really get it, but I don't really remember much about that day at all.
Yeah.
And so it's just this flurry. And then after that, it's just a matter of having the surgery. But basically where I'm at is my ancestors. My heart doctor said it's genetic and you can't do anything about it. Because I was driving at him about how hard I worked at the gym and eating right and all that kind of things. And he goes, well, you can't do anything about genetics.
Yeah.
That being said, my dad's side of the family has a really, really long history of heart attacks and heart problems. There were 5 siblings in that family, and only one of them didn't have a heart problem. His mom, my dad's mom, grandma, she died of a heart attack. Her dad and mom, one of them, might have both of them, I can't remember. They had heart trouble, died of. I would really like to be able to go back and see, but they just didn't have any diagnostic records back then for that.
Huh.
But yeah, I come from a long line of ventricles not working correctly.
Sounds like it. So your previous experience, you said you didn't remember a whole lot about that day, but have you since previously learned about the EMS side of that whole thing, or is that still kind of?
Well, now, no, I remember that part of
Yeah.
it pretty well. It's when I got into the hospital, everybody just stormed me that's I don't remember, but
Yeah.
no, that was the longest ambulance ride I ever had in my life from here up to KU.
Yeah.
So.
Oh yeah, I bet. Yeah.
No, there wasn't anything. The guy that was back there with me was nice. He was funny, all of that. So helped me all he could.
So you kind of mentioned before your day-to-day life before an LVAD and then kind of changing day-to-day. Was there a major shift in that? Is there something?
Yeah, it's
like
pretty
that?
major. Like taking a shower. They didn't want me to take one for 10 weeks, but
Yeah.
I got released from that to do that. I have to take a bag with my batteries in it, and the controller and the wires and everything. It's waterproof. Well, it's not waterproof. But it keeps the water all off of it.
Yeah.
Because water's not something you want to get
Right.
in contact with that. But yeah, just to act like just taking a shower. It's a big logistic thing. Before I turn the water on, I hopped in.
Right.
I got to get my seat. I got the bag in there. I got to get everything arranged so I don't. First time I did it, I had it hung on me standing up. Well, that's off balance.
Mm-hmm.
And I slipped and I went clear out out the shower curtain and caught myself on the toilet. And my daughter, of course, was there. She goes, "Are you okay?" She thought the world. I go, "Yeah, I'm fine. No big deal." But now I've learned to be a little bit more cautious and have a seat in there. Helps a lot.
Yeah. Has anything else changed?
Well, yeah, drag it. I got 6 pounds of weight hanging on me all the time,
Right.
24/7. That's given me a little bit of lower backache, but just something I've dealt with for a long time. But I get all my food delivered. I don't like to go shop for food. It's just too much right now.
Yeah.
My legs are still weak and everything. I'm not afraid to go in a store, but I don't want to go in there for like shopping for food. So I belong to a membership that delivers my groceries and my medicine or whatever I need. So, but day to day, it's I'm getting used to it.
Yeah.
It's just you got to change the batteries to the right place. Get off what they call a wall power at night that you sleep with, because that'll only reach so far, and it won't reach my coffee maker. So I've got to change. I got to change the batteries. So it's just little bitty things like that you would never think of. Now, the other day, I mowed my yard and ran a weed eater all day. It wasn't bad. Wasn't that bad. I did it pretty easily. I just went slow.
Okay.
Yeah. Because the reason I wasn't doing it because they told me with this pacemaker, what this
defibrillator,
ICD is that what?
Yeah.
Okay. They are the ones that told me not to be running motors and never could run a chainsaw again. That was a big deal to me because I run a chainsaw since I was a teenager. But I buy my wood now, so it's all okay. But so I was relating that to weed eaters and things like that. I called to ask them if I could still go to the gun range and shoot because of the recoil.
Yeah.
And they go, "Yeah, just don't put it on there." Well, I don't because it's over here. And then I got to talking to them, and she goes, "No, the only thing you're restricted from using is an arc welder, a chainsaw, and don't lean on running motors, like on a car or something. Does something to this, but she goes, as long as you keep that a foot away from your defibrillator, you'll be okay." All right, I'm off and running then.
All right. I'm gonna switch gears and go over to Ashley. So, can you kind of give us an idea of what an LVAD is and how it relates to how a patient might get one?
Yeah. So LVAD stands for left ventricular assist device. It's a pump that's implanted in the left ventricle, which is the main pumping chamber that gets all that good oxygenated blood to your body so it works properly. I think, as we know with heart failure patients, that stops working so great. So when patients get LVADs, they are at the end stages of heart failure. Like it's kind of that's that or transplant could be an option, but LVADs
like a bridge.
Yeah. But the LVADs really helped get a lot of people a second chance that they were not going to have.
Beautiful. So for us, pre-hospitally, what's
pre-LVAD?
Well, pre-hospital EMS providers. So for us, what is something that what's like one thing that we should like understand about LVADs?
So, if you were to come upon a patient, most of the time they're not going to have a palpable pulse. So, of course, normally as a healthcare provider, palpable pulse, you start CPR. But with the LVAD, that's a totally normal thing. So, things that, we tell EMS you should look for if the patient's talking to you and stuff, and you're like, okay, there's something different here. So, you can look at their controller and see, is this running? You'll know they have a line coming out of their belly, things like that. And then if you come upon a patient that is not able to talk to you, and you can check for other things like cap refill. You can, if you have capnography monitoring, put that on them, do EKG, things like that. So just a few other pieces. And then, of course, listening to the apex of the heart, you can hear if the pump is running. Sometimes you can hear heart tones, but usually the pump's so loud you can't.
Yeah. So we talked in the demonstration video that we did earlier today. We talked a little bit about flow rates and MAP and all that stuff. So how does that all tie in for us? Like at what point should we be concerned with doing something?
Yeah, so I'd say if you are checking those other things, and then, a key thing for blood pressure, an automatic cuff is probably not going to work on a patient, or it's going to give you a reading like 40/20 or something.
Yeah.
So using Doppler blood pressure, which we talked about, having Dopplers on the trucks would be good.
Right,
but
it would be awesome, and we would love to have Dopplers.
Yes.
But
very important for them to have. Yeah.
But can we do just a palpable pulse or a palpable blood pressure?
You can.
Is it reliable? A good reliable indicator too?
Like to just without the Doppler?
Yeah.
Usually not.
Okay.
Yeah. So definitely a Doppler is the best, especially if a patient is having an issue and they might be a little bit on the lower end. And then I know we showed you like an example of how to do it, which and a guide on that.
And you said that most patients have their own Doppler at home.
Yes, at least through our health system, we try to get them in.
So we could definitely use that.
Yes, yeah, and when we're doing training, we always tell a patient caregiver, they have their backup stuff, but it's like if you have your Doppler, which do you have yours yet? Did you get it from? Because some of the like VA can be a little slow sometimes about getting the Doppler to them. So yeah, there's a couple other assessment tools, and then a big thing to know, which I know we do it, and I'm pretty sure it's pretty universal on all the patient's controllers, is the on-call number, because every VAD center will have an on-call VAD coordinator. Like they have to.
Right.
And we generally call back within 5 minutes.
Okay.
Yeah. So always good to have them on the line just to, help you assess.
Yeah. So we talked about that flow rate. What is like optimal flow rate for a patient?
Like for Doppler blood pressure?
Well, just on the screen itself. Like what am I looking for on that screen as far as flow rate?
Yeah, so for the flow, it's hard to say because each patient's numbers on their VAD are a little different based on their speed and other settings. Like when we set their hematocrit, that can change their flow. So the things you want to look for is like, are they having an active alarm, and like what the alarm says, which almost every alarm says to call the hospital, and then look for the little green arrows on there, which if those are running, the pump's running. But if you are having, I know we talked about like the low flow alarm in particular, which can be, I feel like that's the most common alarm, and typically it's for someone that has hypertension. But it could also be if they're having an arrhythmia, if their heart is not actually beating and so nothing is going through there, then that could be it as well. So just looking at those other assessment pieces and then paging us so we can help too. Yeah.
So we did talk about MAP, and AHA has their guideline for a good MAP for these type of patients. So is there a range? Is there just like a number that I should be concerned of? Like, am I concerned with anything above a certain number or below?
So our target range is 65 to 85. I'd say if you're anywhere between like 60 and 100, good. If you're above 100, like, okay, this patient's pretty hypertensive, so should deal with that. And then, of course, if you're getting below 60, and then if it's below 50, and if you have the like ETCO2 monitors also showing and the patient's not responding to you, then that's usually when they say initiate CPR.
So what am I looking for in tidal?
So in tidal, if it's below 20.
Okay.
So if it's below 20, and then you have a Doppler map below 50.
Okay. All right. So when you go and give, what's one thing that EMS should really know when we're dealing with a patient that we're just not quite sure what the problem is? They may be, unresponsive. They may not have an alarm or, something like that, but they're just, that way. What should we be really kind of going for and assessing for those patients that are that way?
I guess the main things would be like, do they have blood flow? Like, is blood perfusing? Are they breathing? And things like that. I feel like the main thing that patients have called about, patients have alarms and they get scared, which we do a lot of education on alarms, but they're loud,
And I had to call, and it was kind of funny. I just got up in the middle of the night to go to the restroom like that many times. And you got to drag this cord around with you everywhere. But when I went to get back in bed, the box that converts it from AC to DC just went nuts. I'd never heard anything like this before. It wasn't the common alarm, and it would not. Everything I tried, it wouldn't go off. I couldn't silence it or anything. Being working in the electrical field, I checked every connection I had, and there was nothing wrong. I checked it twice. Finally, I had to call the number that you're talking about, and it was on a week, Saturday night or something. And they couldn't figure it out. And so I guess we were about to get short on time, because all of a sudden she said, "Why don't you just change your batteries real quick?" I said, "Okay." And so the first one I changed, the alarm.
You just have a funky battery?
I'd never had it. So I said, "Well, it went off." And I took it back out, see if it'd go back on. It didn't. It reset itself or something. Everything was just fine, but they had no idea. They were completely confused about it. They didn't know where to go with it, but somehow taking that battery out reset it or something. But all I did was go in and come back and sit on the bed, and that thing went off.
Were you hooked? And you were hooked to battery?
AC wall.
I wonder if maybe you had like a static electricity type of thing.
Could be.
Because static, especially with this pump, like sometimes static electricity can like make it turn off.
Interesting.
On the AC. Yeah, I wonder if it was something like that.
I don't know.
Maybe geocarpet?
Mm-hmm.
Yeah. I bet it was that.
Interesting.
And I dragged that fitting along, where it fits into it on the floor, so.
Yeah, I wonder if it was that.
I don't know. It sure was weird. I know what to do next time.
Yeah.
All right. So what are some do's and don'ts that we should be looking for or not doing for like ventilation and airway stuff. Is everything okay for airway management?
Mm-hmm. Yeah, there's no typical ACLS protocol. Like, there's nothing special with the VAD when it comes to that.
Okay. What about cardiac arrest? Anything different?
No.
No.
Just so for I guess for the pad, like if you're you don't want to do like the front of chest and side, you want to do like front to back because you just don't want to put it like on top of where the pump is. Yeah. But yeah.
So defibrillation, cardioversion, pacing, all of that is okay.
Yep.
And then and Lucas, right? We can definitely use the Lucas on these patients. Awesome. So what are some common LVAD emergencies that you see EMS called for?
And alarms, like if patients, especially maybe newer patients that haven't had an alarm might get kind of nervous, especially if they're not feeling okay, which is totally appropriate, especially if patients not feeling okay and they're having alarm. Just call. I say falls too are one, and then shortness of breath, or also just because they do still have heart failure. Stroke-like symptoms, with the LVAD, just at risk of having a stroke. So I'd say those are the most common things. Usually it's something that has nothing to do with the VAD. It's more the patient and the VAD is there. Of course, if they have the alarm, and usually it's something, like I feel like the backup battery fault and controller fault alarms or something, like those really scare people because they think like, oh, it's not working. But we also tell them like it's just something with the equipment. Like as long as those green arrows are on, your pump's on, and it's just something like silly, like we have to change out a battery inside of it or change the cable thing. But it's usually not that the pump is not working. So that can be kind of scary, especially if you're not used to it.
Right. Right. So we were talking about these patients. You said that they still have those respiratory problems. Are these patients still good candidates for CPAP and BiPAP and that type of thing?
Yes, if they need it, yes.
Okay.
Which sometimes too, like the capnography is really great to have because sometimes like that, like pulse oximetry, like those might not very well on the patient. So if you don't want to attach it to the ear, try the forehead. Sometimes those work better. So just like a little. Yeah.
So we do have capno.
Okay.
We have nasal capno.
Okay.
So we monitor those patients.
Okay, good.
Remembered my question. So when we go and pick up these patients, obviously, I mean, and you said that 99% of it is sometimes not even anything to do with the LVAD, right?
Yeah.
Why they're calling us. But they have the LVAD.
Mm-hmm.
Is it appropriate to just take them to like Mercy and first and then have them transferred out, or do you want them up there?
No. Taking them somewhere here first would be, especially if they're having like stroke-like symptoms. Like they have healthcare providers here, they have CTs here. Yeah. Most of our patients live 2, 3, 4, like more hours away. Like we hardly have any patients that live locally. So definitely it's, safest to take them to the closest place to be assessed, make sure they're stable and good. And a lot of times they don't have to come to us.
Right.
Like, and usually it's nothing. It's volume overload, but obviously if it's stroke, then they make sure they're stable. Then they eventually they transfer them up to us because if they need admitted, they have to be in an LVAD hospital.
Right. So with that, and obviously the hospital staff here, like at Mercy, is gonna call you guys, and they're gonna consult with your physicians, right?
Mm-hmm.
And do some consulting work to figure out the best plan of action and course, right? So for us, that would be like calling the coordinators, right?
Mm-hmm.
Do you want us to kind of call before we transport, or after we've transported, if it's something to do with the device?
If it's definitely something to do with the device, I mean, I think it's better to page us like immediately, as soon as you can. We even tell the patients, if you're calling 911 and you're able to, call 911 first, because you also want to get someone there, but then page us so that maybe we can be on the phone with you when they arrive. Or, we'll have caregivers call and say, hey, like, Bill passed out. He fell, like, hit his head. And then we'll say, okay, like, you call 911. I know you're there. There's nothing wrong with the device. And then we, ask them, like, sometimes we'll stay on the phone and say, just to see, like, where you're taking them so that we can call that hospital, ourselves. And just so they have our number. And then, because we know so much about the patients too, so we can kind of give them a heads up. So it never hurts to, I think, call.
Yeah. But
obviously, if the patient's unstable and you got to try to assess that, then, deal with that. But
yeah. And can you guys, we talked about interrogating the device earlier, and that's basically, looking at all the alarms and making sure that the device is, working properly. Can you guys do that remotely, or do they have to do that in clinic? Or
do it in clinic for like a longer picture, but there's a button on there, or a couple buttons like you can push to see what their current readings are, and then there's buttons you can push to see what their last 6 alarms were. So you can see like very basic and then real time things. But if we want to see like a longer picture of something's been happening, then we have to plug it in. And
but you can't just like, I know like with some AICDs and various things like that, you can't just like call a phone number and it interrogates the device like that.
No, and that's one of the things that I feel like Abbott's the only one on the market in the U.S. and they've randomly talked like, oh, wouldn't Bluetooth be nice? Like,
right?
Yeah, it would. What's
connected to an app? And you can just log into the app and then thinking.
Yes.
So So how should we, going along that line of thinking, how should we communicate with you guys? Like, I know phone, but what are the things that you're going to ask us, and what are the things that we should be like willing to give to you?
Yeah, well, definitely, we'll want to know what their blood pressure is, like how they're feeling is what are they presenting. If they are
and
having,
preferably that Doppler.
Yeah, the Doppler. If they are having an alarm, what does the alarm say? Like, what is it? And then if you're able, and we can tell you how to scroll through. I mean, there's only 3 buttons on there. You're not going to hurt anything touching them. Scroll through and see what the numbers are. And then, like, those things are helpful to know, so, you could page and then, and which I know, like, one of the first things you're doing when you're assessing airway and checking the rhythm and stuff, like, see is, like, if they're having, like, low flows, for example, is it because the Doppler blood pressure is high? Is it above, 90, close to 100, and that's why they're having these low flows? It's the EKG showing, like, an arrhythmia. Could they be having low flow because of an arrhythmia or something like that? Or are they having low flow because they are so dehydrated in it's summertime and we were out on the golf course and forgot to drink? I'll be you next summer. Yeah.
So you basically want us to tell you what we see in that patient.
Yeah.
So all of the things that we see medically.
Yeah.
The various things like that.
Yeah.
So
the numbers, if you can get to them, which you should be able to, but if you're trying to figure out what to, I was gonna say, we can.
Sure.
Yeah. So even if you're having an alarm or anything, these green arrows right here, as long as those are on, the pump is running. So if you have an alarm, the alarm would show up on here and it would tell you what it is and what to do. And then if you want to see the numbers, this button over here, you push and you scroll through. So the speed, revolutions per minute, that's set. You will see it fluctuate a little bit. That's totally normal. It's sensing pressure changes in the chest.
Yeah.
Flows, liters per minute, an estimate of how much blood is going through there per minute. PI, so PI is your pulsatility index. So that tells you how much work the heart is doing versus the pump. So the higher this number is, so if you're getting to like 7s, 8s, and above, they're probably going to be hypertensive.
Yeah.
This is normal. Being in the 3s, that one's going to vary the most. And then power, that's just how many watts it takes to maintain the speed. And that one's going to be a pretty tight one. So just knowing what all just you read them off to us. We can look at the patient history, see is this normal for them? Are they, normally running like this? I'd say if any of those numbers like fall below 2, we always tell the patients get a little nervous. Like if PI is below 2, their blood pressure is probably a little bit low. Like when we're in procedures with patients and they're first giving them sedation, that PI starts to drop and goes like 1.5, and we just sit there for a second and it comes back up, but it's like when that sedation's first hitting. So if you see if you see a low flow, it's because the flow is staying below 2.5, and then like the PI, you won't have an alarm for that. But if you're having a hard time getting a blood pressure and this PI is below 2, then that's why their blood pressure is probably real low.
So just so we're all aware, there is nothing that I can change as far as flow rate or anything like that on that device.
Nope.
Right?
And then if you want to see the alarms, you push these 2 buttons. Yep. External power disconnect. So that's probably, maybe you unplug, you push these 2 buttons and then you scroll through. Low voltage, that means his batteries were going low. And it'll tell you the date and time. The date's in like European format.
See,
you're doing some crazy things on 11-2.
We're all learning something.
11-2.
Mm-hmm.
That was Sunday.
Oh, yeah.
Yeah.
he remembers.
So I'll show you the last 6 alarms. Let's see. No, it was, it's shortly after midnight.
Oh.
Or wait, no, it's 10. You're right. No, you're right. It was 10:38.
Was that when you were weed eating out there?
No.
Okay.
No. I'll tell you another little thing. When you put this in the pocket, put that to the front because it'll bruise the
no, that's good to know.
It really rubs all the time.
So I do see that you have kind of like a shirt that has all of it on there.
Yeah, there's pockets in it. Like, I don't want to take them out.
Yeah, no, you're good.
But this was kind of tough, but the battery goes right in
here.
And there's all kinds of stuff. Some of it works good, some of it works terrible. I've never found any of it works great yet.
Yeah.
And they're pricey.
They are, yeah. And we the patients do get wearables from Abbott. Like there's like a little crossbody bag where everything's kind of shoved to the side, but kind of similar to how you were talking about the shower bag. It kind of pulls on you. Then there's like a holster mesh vest. No one really likes that. The shirts are really great, but they are pricey. We've had some patients that'll go to like Bass Pro and get fishing vests and put everything in the pockets on there. So there's lots of options to wear. We have a couple ladies that, get really cute purses and put it in their
Something
purse.
I'm going to try that just occurred to me on the way up here today. Those
the football pads?
No.
Oh.
Pistol holsters.
Oh, yeah.
On the leg, that the police all wear, a lot of them, and the SWAT guys. Well, I've got one that's got tons of pockets in it. So I'm going to start playing with that.
So we should, yeah.
Just wear it on one side.
I wonder how that would be for golfing, too, if it'd be better to have something there instead of up here.
I'll figure it out.
I was going to say, yeah, you'll let us know. We do have women, like, we had men too, but we've had a couple of women that want to wear dresses and stuff they don't want to show, so they wear like football pants and they just take the pads out and they put all their stuff in there.
Yeah.
I've got a pair of, this is one of the first things I ordered is like riding a bicycle or real tight.
Oh yeah, like bicycle shorts.
But they got pockets in them. Well, I lost a lot of weight, 6 pounds of batteries. It just eventually starts pulling those pants right down. Pants don't work very good, I don't think.
Yeah.
But these shirts here are the best I've found.
Yeah.
No, they're really nice.
And then I have a leather vest that's a real close second to this. It's not hardly know I have anything.
Interesting.
So,
very cool.
Yeah, so that's the thing now. Like, it's really great. I'm sure that presents another challenge for you guys because now there's a way to conceal it, whereas before, like even 10 years ago, I mean, you could see everything.
Yeah, and I'm thinking in my head, how would I go about,
feeling like so you're just cutting clothes off.
Yeah. So how am I gonna thinking about cardiac arrest? Heaven forbid you go down right here. I don't want that. But with that shirt on, you've got everything like tucked in there and zippered and various things like that. We've got to get our shirts off. We've got to get to bare skin for those pads.
Yeah.
It wouldn't be that difficult because you can't get anything over the drive line. Okay, you can't be tied. It won't tuck in or anything.
Yeah, the drive line.
It'll always be loose.
Oh, okay. All
Is
there like one zipper that just kind of unzips on the whole thing?
No, the zippers are for the battery pockets.
Yeah.
You just have to
This
be.
is just pull over.
Oh, okay. So it's just a pullover.
But you see, I can't get it tucked in because of the drive line.
Yeah.
You just have to be careful. Like if you had to cut somebody's clothes off, that you just don't cut any lines.
You can mess with all the lines, but don't mess with this.
All right.
Yeah.
Pull hard on it.
I learned earlier that you don't get an extra one of those.
Yes.
No. All they need is a little bit longer.
I know.
I'm gonna keep saying it until somebody listens.
Yeah.
Former engineer. I know.
There you go.
Believe me, you're not the first one that said that.
There you go.
I dealt with stubborn engineers for 20 years, so.
We need to get you with the people that make VADs so they can make it longer.
You're just gonna keep driving.
Yeah.
What are some mistakes that you see well-intentioned providers make sometimes?
Doing a controller exchange when they didn't need to because there was an alarm, like a controller fault. So they think, the controller doesn't work, so I'm going to exchange the controller.
Because they do have two controllers. They have a backup controller, and then they have.
I have it. I just left it in my vehicle.
At least it's on campus, yeah, because they do have the backup. Because we tell them, it's not. Knock on wood. And the whole time I've been doing this, I've never had someone's controller just fail. But it is still a computer that could still happen. So we always tell patients, like, have your extra one with you just in case. Have extra batteries just in case. I know these batteries are going to last you 14 to 18 hours, but you never know. Have it with you. Not in the car. But, and that's more, I'd say that's more, extreme hot and cold temperatures can affect the equipment. But it's a pretty nice day. We know where it is. Nancy and I are here, so you should be good. But I'd say, when you see an alarm, especially one that says fault, and just assuming, oh, this is broken, let me switch to the other one, which anytime you're switching to the other controller, you are stopping the pump for a few seconds. And, that's enough time for a little clot to start to form. It's pretty rare. I mean, you probably have to have it unplugged for quite some time, but, I haven't had this happen. I've heard stories of people trying to do controller exchanges and not lining up the arrows, for example, and then they bend pins, and then you can't get it back in.
Yeah.
We have not personally experienced that, but I have heard that. So especially in an urgent situation.
Let me tell you about EMS.
Yes.
Because if there is a way that we will screw something up, we'll find a way. Now, we're hard on things. I mean, we are.
Yeah.
And I know that I'm sure when they were designing these devices that they were thinking, okay, these are going to go home with patients. Because before, I go back to the episode on Grey's Anatomy with Kenny or
Denny Duquette, yes.
Denny, and his LVAD and him having to live in the hospital for months.
It was one of the hand pump ones. Yeah.
Months at a time. And I think about that and thinking, how far it's come now, that you can go home and live a relatively normal life, right? Without having to stay in the hospital.
A few changes.
Yeah.
And the equipment, it's definitely, it's robust. And we have people that are rough on it. There's some people we have to, they come in and we see like mesh sticking out from, the cords are very well protected. They have multiple layers of protection, mesh, poly, and all that stuff over them. So it's pretty hard to damage them.
Yeah.
But I'd say it's more like if you were trying to do some sort of an exchange and you're trying to
jam those pins in there.
Yes.
Yeah.
But they're arrows.
There's one little pin above it that's kind of by itself. The rest of them are kind of protected. They've got to go in a certain way.
Yeah.
But there's one little pin at the top that you got to be really careful just to. I saw that right away. It's easy to bend that thing if you have it out of line.
I bet. Yeah.
And the other device, which there aren't as many of them, we only have a few patients living on the hardware. Those pens bend.
Yeah. So what are the other devices? We've got the hardware. We've got the
HeartMate
2
2
and 3.
HeartMate 3, yeah. So Bill's a HeartMate 3, and that's a majority of patients you're going to see right now. But there's still the HeartMate 2, like all the external components work the exact same. But then the hardware is a little different. And those pens are a little bit more delicate. You just got to be real careful the way you're doing that.
So in regards to the information that those devices, like the hardware, is it going to tell me all the same information, or is it going to be like slightly different?
Like the
flow
EMS
rate and the flow rate,
it'll still be
all
the
that
same.
stuff.
Yeah. So they don't have a PI. They have a peak and a trough, and then we subtract those to get a PI pretty much. So,
Okay.
but same thing. That's why every VAD center has a VAD coordinator on call 24/7 for that reason, to assist in those things. Yeah.
And I know in most of our trucks should be our little LVAD books that we've made. I showed you guys earlier.
Yeah.
And it kind of goes into explaining each of those devices and how they work and all of that. So my hope is that our guys are well prepared when they have to come to you in some type of incident.
I'll guide them.
Right, because you know more about this than I do. I guarantee it. I've been in EMS the last 20 years, and this is the LVADs are foreign to me. Like, I guarantee that you, as my patient, would know more than I do about the LVAD.
I didn't know about the idea they had such a thing until 2 months ago. I didn't even know what they were talking about when I was in ICU.
Yeah.
Well, I don't know what that is,
Yeah, and now you know more about it.
Yeah.
What was the biggest? So let's go to that. So, what was kind of the biggest hurdle in learning this device?
The biggest hurdle was just managing it all. And, I'm still not used to wearing all the weight. It still gives me a backache. I mean, I put it on in the morning and I get a backache. But as far as you got to get around the house, okay? So if you're plugged into the wall, you've only got so much room. But me being like I am, I have extension cords everywhere, so I can figure things out. I mean, if I just have to. So far, I haven't had to. But just things like that, here we go back again. The biggest aggravation is this driveline cord being too short, because if I'm going to the bathroom or I'm getting dressed in such a way that I'm sitting down, it's hanging that far off and it's just pulling. It just makes the whole deal by itself pretty miserable at times. I can't tell you one great big thing. It's just more
trying to keep it straight.
That's the part that's hard, that Nancy, Ashley, I'm sorry.
You're good.
All of them have told me that 2 or 3 months, I feel almost like I did before any of this happened.
Yeah. Guess how far out he is from
right now, I don't, but I believe what they're telling me. And I just tell them because it's a lot to think about.
So I know the answer to your question, Ashley, but for those watching, I mean, I personally, it was hard for me to believe that you were only 8 weeks out from surgery.
Is tomorrow the 8 weeks? You said tomorrow's the 8 week, yeah.
So, I mean, for me, that's a little difficult to understand because some of these patients, we take those patients in and they are like super sick when we take them in.
Yeah.
And, getting an LVAD, I can't imagine is an easy feat to have surgery to do. So, you look great for 8 weeks.
Well, appreciate it. I wish I felt better. I'm kind of impatient, want to get going with things, but it's winter time, be a good time to recover and learn about this more and what works best and what doesn't work best. But I'm encouraged about the future by what they tell me, that I can get back to it.
Yeah. Well, it sounds like you're starting to get back
to it fast enough for me. But I'll say one thing about this surgery.
Yeah, go for it.
I've had 3 back surgeries, 2 heart attacks. I got 5 stents in my heart. Okay. And now all of those I was up going the next day without any problem.
Yeah.
All of them put together aren't as bad as this. This absolutely tears you up.
Yeah.
I mean, I had nothing when I felt I couldn't even walk whenever they got done with me out of the room.
Yeah. I was going to ask how recovery was.
It's
I know
you just got to stay with it.
Yeah.
It's not fun laying there in a hospital bed all day long. So,
yeah.
Because that's the worst way to get out of shape, I think. And then there's the food.
Yeah.
But we won't go there. I just accepting what I'm going to have to do in the future is what I'm trying to organize right now, I guess, for lack of a better word.
Yeah. All right. Well, we are just about at an hour. So let's just kind of close up. So for you, Ashley, is there anything like big takeaways that we should take away from this? On the EMS side, like what should we be prepared for to do?
Definitely the getting Dopplers on all the trucks. Doppler blood pressure, paging us. That backup bag, very important. Just have their backup stuff with them. If they're able to talk to you, like you said, the patient, their caregivers, they're going to know a lot about this. So just utilizing them as a resource if able, and just making sure to be more gentle than maybe you're used to, and pull, you don't want to pull cords or anything like that. And just get them to the closest emergency room, and there's always someone on the line ready to help.
Yeah. So even if it is an issue with the LVAD, we can still take them to that closest facility.
Yeah.
And that is completely appropriate to take them to that closer facility.
Yeah. And, the other device, I had a patient in this area that device quit. It was a known malfunction of that device. Mm-hmm. And so brought them to, I believe, Mercy Hospital, and they were able to start, the valve wasn't working. So they were able to just get them on dobutamine, stabilize them, and transfer them up to us. But we definitely don't want them just cruising along the highway with you guys, and then you don't have the things you need to help support their heart if the pump were to stop. So always good to get them somewhere and do imaging, start do the things you might need to do just so you can travel safely up.
Yeah. And speaking of travel, you've got lots of equipment, right, that has to be taken with you anywhere you go.
That's a big one I've figured out. Is how to fly somewhere, with all this stuff.
Yeah.
The charger is pretty big and heavy. I'm figuring it out, I hope, but not really here.
And it does it doesn't look like it, but it will all fit in one of those those roller bags that fit in the overhead. It does all fit.
Does it all fit?
Yes.
Okay.
And we haven't reached that point yet. 3 months he can travel. And we give you a letter, so TSA, they can't check your bag. If the plane's full and say, we have to check bags, you have medical equipment, so yours has to stay on the plane with you. It all fits over.
You're going to give me something for that?
Oh, yes.
Because I've heard of it, but
he's chomping at the bit to go fly now.
Yeah. I haven't had patients have issues. We have someone that goes to Germany every year. We've got people Vegas, New York,
Because my brother, he's always hit me with the best credit card for miles.
Yeah.
But they're world travelers. They're in the Cook Islands right now, in South Pacific. So he's trying to get me to do it. I'm not that big crazy about traveling all over the world.
Yeah.
Something
But
like
I mean, this gives you the freedom to do that, right?
Yeah,
I mean,
yeah, it does.
it doesn't really restrict you. I mean, unless you've just got issues or
Just
clinic
gotta
appointments
get
and stuff.
a letter from
Yeah.
it.
And I've never had anyone have an issue with the letter or get stopped or crazy searches or anything like
You
that.
get on
And
a plane first.
yeah,
You don't
no one like gives you, like, when they see that letter and they see that you have this coming, they don't want to mess with anything. They just pretty much let you do whatever.
Well, I was wondering about that because it kind of looks like I got a bomb vest.
Exactly. So that's why we give you the letter. They say, "Oh, your equipment." And they're just like, "Okay, you have a letter. You're good. Just go. Just."
Something I'd like to add that
Yeah.
you're dealing with an LVAD patient.
Yeah.
I haven't had it happen, but I can imagine how freaked out and panicked your patient's going to be because that stuff's going to quit.
Yeah.
And thinking they're going to die in 5 minutes if you don't get it going back again. And it may not even, it probably isn't even what you're saying anything to do with this, but that's the first thought.
Yeah, definitely.
I can see that. So you might run into a really panicky, upset person, I can see it happen.
Yeah. Yeah, I think we have seen that before where patients will get sent home on the device and it's still brand new to them and they're just, unsure of all of the alarms and all of the little nuances for it. And then they call us and then we have to, try and work through that, figure out what's going on. So,
Yeah, and if the VAD were to just stop, they're still going to have like their native heart function. So they're going to be used to having that good flow of the VAD, and then all of a sudden they're not going to have it. So they're probably going to start to like decompensate, but they're not just
not going
to
like
die.
Boom.
Yes, yeah, like my patient I mentioned before, like had enough preserved function that started on dobutamine, got him up. Of course, it was during a storm because why not? There was no air.
Yep.
So had to come via, why not? Like all the things that could happen, but was fine and stable when he came. So that's a good thing to take away too. And for patients, we try to tell them like, hey, like you're probably just not going to feel really good because you are going to get used to feeling that good flow, and then all of a sudden it's going to go back to like before when you were in like just heart failure at all times. So
yeah. So I know we said earlier that most of those patients will have a good amount of time before really intervention needs to happen or anything like that, right?
So we don't.
Ish.
Like you don't want to. I try to think how to answer the question. Yeah, you're gonna have time. You just don't want to. I don't think that's how you're asking. I think that's how I'm reading. Like, don't you guys just sit there? Like you just call. Yeah. Okay. No. Yeah. Okay.
But for us, it's okay if their device is not working.
Yes, and you definitely
for the most part.
Yeah, you definitely want to assess things to try to get it. Like if their batteries are not, like look at things like, okay, are their batteries not hooked up? Is the drive line, did it come out? Like you want to try and get it hooked up as soon as possible. Unless of course, after about 15 or 20 minutes, if it's off, most providers won't want you to restart it because it could have a clot in it. Now we've had patients that have gone hours just not doing anything, not many because there are, but and they turn it back on and then it's fine. Just a couple. Not you do what you're supposed to. Yeah.
Well, I'll give that a try.
Do not.
I think you're going to be in trouble if you do.
You don't want to test that. But no, you definitely don't want to take that risk. And, if it's been over like 15 minutes to restart it because there could be a clot, you restart it, it just shoots that clot.
Right.
And I tell you, I can't believe the difference in how I feel prior to this versus now.
Yeah.
It's just like I've not had any shortness of breath at all, not even in the hospital.
I know, you said you've been sleeping. That's good.
Yeah, and before that sleeping was kind of a bad habit I developed anyway. I'm not sleeping very good. Because my wife passed away of cancer 6 years ago.
I'm sorry.
5 years ago. I was her only caregiver, and I slept with one eye open for 6 months.
Yeah.
And I kind of got in the habit of not sleeping very deeply. That's carried on for 3 or 4 years now. And with that, with me waking up short of breath, I was always, I didn't even want to go to sleep.
Yeah.
Honestly, because I didn't know, I got to wake up in time. It'll wake you up, but like I said, the last time there was just something different, so that's why I called.
Mm.
And I'm really lucky in that because my daughter's father-in-law lives 2 minutes away from me, and he's an EMS guy.
Oh,
He's
yeah.
in the fire department in Aurora.
Oh, yeah.
Yeah, so if I call them, they're going to get him right there in 2 minutes.
Yeah.
I think he's kind of got me on a list of addresses and watch too for the other guys. So
Yeah.
that'd be handy if you had LVAD, list of LVAD patients in your community.
So we do.
They do.
They do?
Yes.
Yeah.
Yeah.
So
Cool.
so our dispatch, they email us. You guys do your coordinators, and let us know that hey, there's an LVAD patient that is new to your area or is in your area, and they give us the address. They typically give us like a medical history and just a shortened type of deal, and then what kind of device you have. I mean, obviously it's the HeartMate 3 now, but but yeah, and then our dispatch will put them in. We'll just come flag your address in our dispatch system, so that way we know that before we get there that we're going to an LVAD
A little
patient.
bit more cautious.
Yep. So
well, I don't sleep with a shirt on, so it'll be real easy to see if it's me and know what's going on.
Yeah. All right. So, what's one thing you want EMS to take away from this?
Me personally,
Yeah.
they've already told you that the person could be really emotionally upset. That doesn't ever help anything. You've got the EMS working on you.
Yeah.
But then again, it's hard to relax in a situation like that. Most of that comes from, I think, misinformation that, we really do have a little bit more time. And until your time's up, don't worry about it. So
right.
They're going to do everything you can. Trust the EMS.
Yeah.
That's what I'd say.
All right. Ashley, any final thoughts?
No, it's I'm very glad that you guys are doing this, and I think this is a very wonderful thing as more VADs are out in the community and doing great just like you. So just thank you very much for having us and doing this.
I appreciate this.